All right, now having become familiar with microbial pathology, let's move on now to the science of epidemiology, which is uh, merging the science of the study of illness with the study of populations and the study of geography. So let's move on now and study a little bit of, or learn a little bit of epidemiology. Okay, so epidemiology is the study of patterns of inheritance, right? Patterns of disease within populations. It's a relatively new science, probably 50, 60 years old, that was the result of a fusion between microbial pathology, and demography and geography. Right? So what an epidemiologist does is usually they do their best work when you have a new disease and nobody knows what's causing it and nobody knows how the disease is transmitted or how it works. And what the epidemiologists will do is they will start looking at the patterns. Is there anything in common among all the people that catch it? Do they live in the same place? Do they get water from the same well? Are they all the same age? Are they all the same sex? Are they all touching the same type of fomites? Do they all work in the same profession? Are they all working in the same building? Those are the things that epidemiologists do in order to do this kind of detective work to figure out what exactly is causing this disease. All right, so we just learned that the morbidity rate is how many people have the disease, and the mortality rate is how many people who have it will die from it. The term prevalence is another term for the morbidity rate. Basically, it means what percentage of the people of a certain population have the disease. So instead of asking specifically for the morbidity rate, you ask how prevalent is that disease in a certain area of the world, for instance. The word endemic. An endemic disease means it naturally occurs and it's fairly common for a certain part of the world, right? So, for example, malaria is endemic to areas of the world where you have people, mosquitoes, as well as monkeys, right? So therefore, malaria is endemic to certain parts of Africa and certain parts of South Asia, where you have people, monkeys, and mosquitoes all together. You will always have malaria. So malaria is endemic to those areas. In British Columbia, we have Lyme disease, for example. So Lyme disease is endemic to British Columbia. There's another disease called Rocky Mountain Spotted Fever, which is caused by a bacteria called Rickettsia, and Rickettsia is endemic to British Columbia as well. Malaria is not, because we don't have any monkeys here. Okay, so an epidemic is where you have an outbreak. An outbreak is where you have a sudden appearance of a disease in a small area. If you're lucky, you can contain the outbreak and it won't go any further. It won't go any farther. If it expands to a large area, like within a country or confined to one or two countries, you call it an epidemic. And then if it spreads to the entire world, that is the definition of a pandemic. The word pan is an ancient Greek word meaning everything, all over the place, everything. Right? So a pandemic refers to a disease that spreads over the entire world. So influenza generally causes pandemics, and COVID-19, the SARS coronavirus, causes pandemics as well. That's why we're taking this course through Flex Learning. Okay, so here we have some graphs just documenting the number of outbreaks of a certain disease by year. The lighter colored bars, this is a bar graph, of course, rather than a line graph, and the lighter colored bars refer to the the morbidity rate, and the dark ones are labeled as deaths in the legend. So this is a legend. A legend is the part of a graph that shows you what the symbols mean. Right, so the legend is telling us that the lighter bars refer to the mortality rate per year for a certain disease, and the dark bars refer to the mortality rate, and the light bars refer to the morbidity rate. All right, now we already know what signs, symptoms, and etiology are. What you may not know is that there are some diseases that are so contagious and diseases that are highly contagious and have a high mortality rate. And generally, in most parts of the world, those diseases are what are classified as notifiable diseases. So I might ask you on a test, what is the definition of a notifiable disease? A notifiable disease is where if you go to the doctor and you're diagnosed with that disease, the doctor is required by law to tell the government. and that disease is usually accompanied by a mandatory quarantine. That means by law you have to go into the hospital until you're better. And in addition, they will do case tracing, where they will get somebody to come and ask you how many people you've had close contact with in the last two weeks or 3 weeks, and you have to make a list of everybody that you've been in close contact with. And then those people as well have to be checked for the same disease. So a disease that is highly contagious and has a high mortality rate is generally a notifiable disease. A notifiable disease is where the doctor, if you are diagnosed with that disease, the person who diagnosed you with it is required by law to tell the government. In the United States, the doctors are forced to tell the CDC, the Center for Disease Control. In British Columbia, the doctor is forced to tell the BC CDC, the British Columbia Center for Disease Control. And then in most places, the law says that you have to go into the hospital until you're better. You're not allowed to just leave and continue spreading the disease. Okay, so example, very obvious example is tuberculosis. So tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. And it is very contagious, and it has a high mortality rate, something like 40% or something like that. So that is an example of a notifiable disease. And if you're diagnosed with tuberculosis, by law, you have to go into the hospital and stay there until you're better. Another example would be the Ebola virus, which is a hemorrhagic fever, causes a hemorrhagic fever. It causes basically Ebola is terrible, a terrible virus with a nearly 100% mortality rate. So if you catch Ebola virus, it's almost certain that it will kill you. It causes hemorrhagic fever, so the internal organs fall apart and the blood is released. So it's a terrible disease. So Ebola everywhere in the world is a notifiable disease accompanied by a mandatory quarantine. All right, nosocomial infections are hospital-acquired infections. So another term for nosocomial infection is referred to as healthcare-acquired infections, or HIAs, but the best term and the most frequently used term is a nosocomial infection. All right, now sadly what happens is with nosocomial infections, when hospitals begin to run out of money, the executives who run the hospital, the first thing they usually do is to lay off the cleaning staff. They say, well, we need the doctors and the nurses, don't we? And we need the x-ray technicians. Maybe the cleaning staff are dispensable, so we can lay them off, when in fact, nothing could be further from the truth. The cleaning staff doing proper cleaning of the hospital rooms in between patients and so on is critical to preventing nosocomial infections. So when people are sick in the hospital, if they have a contagious disease, they blow their nose, they wipe their nose, and they grab the handles of the bed. They pick up the remote control for the TV. They go into the bathroom and they turn on the sink faucets and wash their hands. They use the toilet. They use the handle on the toilet. They touch the door handle to get into the bathroom. They touch the door handle to get it in and out of their room. All of those surfaces have to be very well cleaned. If they're not, then there's a big problem. Right, so that you can transmit the disease through fomites. Right, so hospitals must be immaculately cleaned. They must be very well cleaned, and so it's just too tempting for hospital executives to lay off and cut back on cleaning staff. Now, cutting back on the cleaning staff is a bad idea, but sometimes the problem is not that the hospital has cut back on the cleaning staff. Sometimes the problem is that they are not giving the cleaning staff enough time to adequately clean the room. So when you do something called a deep cleaning, it means you bring in a steam machine, a machine that makes steam, and you fill that machine up with hydrogen peroxide. And then you allow that hydrogen peroxide to essentially sort of fumigate the room. So this hydrogen peroxide gets everywhere and kills off all the bacteria and viruses and things like that. So that's called a deep cleaning. Regular cleaning is the cleaning staff just goes in with disinfectants and rags and sponges and mops, and they mop and they clean and so on. And so that's another thing. Now, many hospitals, for the Canadian healthcare system is a relatively good system, but it needs much improvement. And as citizens, we should be making a fuss about these improvements. We should be demanding that our healthcare system is improved, and they should be constantly finding ways to make it more efficient and better. And so one of the problems that we have is that we barely, in the Canadian healthcare system, depending on where the hospital is, most hospitals have a shortage of beds. They have a shortage of beds. So now when you have a shortage of beds, that you have to move new patients into the bed as soon as the old patients get better and leave. And sometimes there is such a rush to do that that the hospital cleaning staff does not have time to do a thorough cleaning of the room. That happens all the time, and this is a common source of nosocomial infections. And this problem is caused by not having enough beds. If you have enough beds in the hospitals, then the cleaning staff doesn't have to rush to clean the rooms. Okay, so that's one cause of nosocomial infections. Okay, now can you look at the picture on the right? What is this nurse or care aide doing wrong? Right, she's not wearing gloves, right, and she may not be wearing a mask. It looks like she's not wearing a mask, but generally it's better if the nursing staff wears a mask, but it's absolutely compulsory that they should wear gloves. And not only that, but they have to change the gloves in between patients. So the way that this is supposed to be done is that every patient has a box of gloves by their bed. They're made of either vinyl or nitrile. Nitrile is better because fewer people are allergic to nitrile than they're allergic to latex or vinyl. So every patient has a box of nitrile gloves at their bedside. When the nurse or the doctor comes in to do something with that patient, they wash their hands and then they put on a new pair of gloves from that box. Then they manipulate that patient. They do whatever they have to do to that patient, and then they take the gloves off and throw them away, and then when they move to the next patient, they have to put on a new pair of gloves. Right? So they should never go from one patient to another without changing their gloves. Right? So that's one of the critical things to control infection, is always changing the gloves. So if you go and visit a relative in the hospital and they're not doing that, you should ask them why, because they're supposed to be doing that. Okay, so the most common nosocomial infections, we talked about this a little bit earlier. Urinary tract infections are the most common nosocomial infections. In fact, urinary tract infections are usually iatrogenic. They're usually caused by a dirty catheter. Anyway, so the most common nosocomial infections in the hospital, 32% of the nosocomial infections are urinary tract infections. The most common culprits are Escherichia coli and Staphylococcus aureus. Right, so how do these are two bacteria. How do they get into the bladder? Where did they come from? Well, the E. coli gets into the bladder from the rectum, right? So the rectum is very close to the penis and the vagina, and the urinary meatus in the vagina, or the urethra and the penis, right? So the bacteria, if that area is not properly cleaned, you can imagine that it would be easy to get a catheter dirty in that area before you inserted it up into the bladder. The other, Staphylococcus aureus, is part of the normal skin microbiome. So it's very common for if somebody's putting in the catheter and they accidentally touch the skin before sticking the catheter in through the urinary meatus, that can cause a urinary tract infection as well. Okay, the next most common cause is 22%. Last time I saw the numbers, about 22% were surgical incisions that become infected, often by a bacteria called Pseudomonas aeruginosa. Pseudomonas aeruginosa is an interesting one because it is a lot of the hospital disinfectants, a lot of the cleaning agents that you use to clean surfaces will kill most bacteria except Pseudomonas aeruginosa that actually likes it. So you're killing some bacteria, but you're actually feeding the Pseudomonas aeruginosa. So we'll talk about that later in the course. But the hospitals should not be using cleaning agents that contain this particular chemical. Some of them don't know about it, but they're supposed to know about it because the hospitals are supposed to have an infection control agent. So every hospital is supposed to have at least one staff member who is in charge of making sure that infections are controlled. And that person is called the hospital infection control officer. And that person is supposed to know that there are some cleaning agents that you're not supposed to use because they actually encourage the growth of Pseudomonas aeruginosa. So we'll talk about that later. About 15% of the nosocomial infections are pneumonia that's caused, bacterial pneumonia that's usually caused by dirty ventilators. 14% are bloodstream infections, bacteremia or septicemia. And anywhere between 12 and 30% are gastroenteritis. So the gastro refers to the stomach, and enteritis refers to the intestines. So this is an infection of the stomach and the intestines, which is usually caused by our old friend Clostridium difficile. So normally, so you must probably remember before I explained that if people are in the hospital and they are given a course of antibiotics to kill off an infection, they are simultaneously supposed to be getting a course of pills that contain probiotics to put the good bacteria back into their intestine after they've been killed by the antibiotics. Because if you don't make an effort to put good bacteria back into your intestine, the bad bacteria have a chance to move in, and if it happens to be Clostridium difficile, then you get something called hospital-acquired diarrhea. So here's the same thing in chart form, just showing you that around 30% of the nosocomial infections, as you can see, this data comes from the CDC, right, the United States Center for Disease Control, right? And it shows that 32% of the nosocomial infections are urinary tract infections, and then you have all the others that I just explained. Okay, so we talked about modes of transmission, we talked about reservoirs, we talked about passive versus active carriers. A passive carrier would be a mechanical vector, basically. An active carrier would be a biological vector. The term carrier, I mentioned earlier that the term carrier is also used in other contexts sometimes. And so an example is men, for instance, can be an active carrier of a virus called HPV-16. HPV-16 causes cervical cancer, and men don't have a cervix. Right? So men do not have a cervix. The cervix is a ring of muscle that's at the top of the vagina. A cervix is a ring of muscle that closes off the top of the vagina and the bottom of the uterus. So men obviously don't have a uterus or a vagina. So cervical cancer is something that only women get. But men can carry that virus and give it to women, but they do not get cancer from it themselves. So that's an example of where we would call them carriers. Okay, so mechanical vectors versus biological vectors, we know all about that. All right, so we learned about the fact that if you have active carriers, you can have either a definitive host or an intermediate host. This is usually talking about protists that have very complicated lifespans that live in several different forms throughout their life. If you're just talking about bacteria, Lyme disease, I mentioned, is caused by a bacteria called Borrelia burgdorferi. It's just a bacteria. It only exists in one form. It exists as a bacteria. It's a spirochete, and it doesn't have a definitive or a secondary or an intermediate host. It doesn't have a definitive host. Everyone is the definitive host, essentially. Okay, so contact versus vehicle transmission. Vehicle transmission is where the disease is transmitted through water, food, air, or dust. Mechanical transmission can be where it is transmitted through the fur of an insect, carried on an insect's feet, for instance. Vector transmission, where you have biological vectors. We're talking about mosquitoes and ticks. Contact transmission, we have indirect contact transmission through fomites, direct contact transmission through touching, direct transmission through droplets, sneezing, and horizontal transmission, person to person, vertical direct transmission from mother to child, which is known as a transplacental infection. Let's just look at a few common examples, and then we can finish off the section on epidemiology. Okay, direct contact transmission, skin to skin, versus droplet transmission, which is also classified as direct contact transmission. So these people are all wearing masks to avoid spraying respiratory droplets into the gut of a patient who has their guts opened up by the surgery. Okay, so the other thing is that they're wearing masks to prevent droplet transmission, but the scalpels and the scissors and the probes and all of these instruments that you use to do the surgery are fomites, aren't they? So that would be indirect contact transmission through fomites, except for the fact that they sterilize these surgical instruments in a machine called an autoclave, which we'll discuss later. Okay, so here we have paramedics that are treating somebody after an automobile accident. Notice that they are wearing gloves. They should probably be wearing masks as well, but they are definitely supposed to wear gloves. In this case, the gloves, paramedics didn't used to wear gloves in the 70s and early 80s. And once we learned that the HIV, the AIDS virus, HIV, could be spread through blood, through the parenteral route, suddenly firefighters and paramedics and ambulance attendants became nervous about coming in contact with blood, justifiably so. And so they changed the rules that paramedics and firefighters and people, ambulance attendants who treat people who are bleeding should be wearing gloves. That was initially to protect the paramedics. But it also is a good idea for them to wear gloves to avoid them contaminating the patient that they're working on. So it's a good idea to wear gloves anyway. Okay, what about food preparation technicians, commonly known as cooks and chefs? Right, so the instruments that you use to cut up the food can be dirty. They should be thoroughly washed in hot water, very hot, the hottest water you can get. And the food preparation technician should always wash their hands, which is what they always used to do. But more importantly, we now know that washing your hands is not necessarily good enough. A lot of bacteria can hang on. A lot of bacteria and viruses can hang on, especially if you don't do a very good job of washing your hands. So it's better if food preparation technicians wear nitrile gloves. These gloves that are shown here are actually nitrile gloves, right? And you might notice in Columbia College that down on the main floor we have a Subway, and when they prepare your sandwich, they're supposed to change the gloves in between sandwiches, which they do. But they're wearing plastic gloves. Plastic gloves are better than nothing. Those are called food preparation gloves. They are better than nothing but they're not great because they have seams, right? So what they are is they take two pieces of plastic and put them together, and then they have something that looks like a cookie cutter that gets heated up, and then that kind of basically cuts the glove shape out while fusing together the two pieces of plastic. But those gloves can leak. It's possible for those gloves to leak, so that's not ideal. The ideal thing to do would be to have the food preparation staff wear nitrile gloves like this and change them in between every sandwich, for instance. But that would be very expensive, and that's the main reason why they don't do it. And if there isn't anything particularly deadly going around, if there isn't a disease going around that's deadly, then they can't really justify that expense. The other issue is that if some restaurants are nervous about having their food preparation people wear nitrile gloves, because if the customers see the chef wearing blue nitrile rubber gloves, they might wonder that if the chef has a disease, right? Does the chef have eczema or something like that? Is that why the chef is wearing gloves? Because the chef is sick. And then the maitre d' or the owners have to explain, no, that's for your protection. The chef is fine. The cook is fine. So these are attitudes that we have to readjust. Hopefully after the coronavirus pandemic is over, we will think twice we'll have a more receptive attitude towards cooks and chefs wearing nitrile gloves. Okay, and this picture obviously is very wrong. The nurse or the care aide who's handling the patient is supposed to be wearing gloves and a mask. So indirect spreading of disease through fomites. Here we have toothbrushes. We have the bathroom glass. A lot of bathrooms have a glass that everybody who brushes their teeth, they fill up the same glass and then spit out the toothpaste. That's very bad for transmitting diseases. Sharing a toothbrush is an absolute no-no. You should never do that. Sharing thermometers, probably a bad idea. Everyone should have their own thermometer. So these are typical fomites. As you know, money is a terrible fomite. Toothbrushes are a fomite. Bandages are fomites. Diapers are fomites. If babies have diseases that they catch through the oral fecal route, those diapers that go out in the garbage, they end up in the garbage dump. The disease could be spread around that way from animals that tread or track through the diapers. I know that a lot of somewhat disgusting animals like raccoons and things like to tear into bags, garbage bags full of dirty diapers. So it's always a good idea to have the diapers in a garbage can rather than a bag inside a garbage can. So, as I mentioned, these surgical instruments are sterilized. Otherwise, they would make ideal fomites. They're sterilized in that instrument on the lower right, which is called an autoclave, which we'll talk about later. Droplet transmission is a direct, classified as direct contact transmission. It has a range of 2 meters at the most, has a range of 1 meter at the most, or 1.5 meters, and that's why we have now set the limit for social distancing at 2 meters, because that's longer than the range for droplet transmission. Remember that droplets are classified as drops of saliva or mucus that are larger than 1 micrometer, 1 micron, whereas aerosols are water droplets that are smaller than 1 micron and are essentially just steam coming out of the lungs, just water vapor mist coming out of the lungs. If you want to know what the range of aerosols is for mist, just hold a mirror up to your mouth when you're talking, right? You'll notice that if you hold the mirror 5 centimeters from your mouth, when you talk, the breath will fog up the mirror. If you hold it 10 meters from your mouth, you won't see the mirror fog up. So that tells you that the range for mist, aerosol mist, is around 10 centimeters or less. This is incorrect coughing protocol, because if you cough into your hand, you always have to cover your mouth when you cough so you don't spray droplets all over the place. If you cough into your mouth and then you go around shaking hands and touching doorknobs, then you're spreading the disease, right? So the correct way to cough, you can practice this coughing when you're not sick, right? Like just practice the motion, because you may not have time to think about it when you actually cough. But if you practice the motion, practice the motions of coughing into your elbow. Right? Now that, the reason why we do that, so if you practice the motion of doing that enough, it'll become a reflex, so you don't actually have to think about it. If you feel a sneeze coming on, a violent sneeze or a violent cough, and you have to think about it, you will probably instinctively end up coughing into your hand. Right? So practice the motions of raising your elbow over your mouth and tilting your head into your elbow and sneezing, so that you don't even have to think about it, so it becomes a reflex. Now, this is interesting. The reason why infectious disease experts have developed this sneezing technique, because based on the fact that you don't touch anything with your elbow. You don't touch anything with the inside part of your elbow, whereas you touch everything with your hand, right? So they said, okay, let's get some convenient body part that you can sneeze into that doesn't actually end up touching anything later on, and that was the reason why we did this particular type of sneezing. All right, now in the coronavirus pandemic, we're looking for alternatives to shaking hands, because shaking hands is no longer safe. Right? So there are social distancing we have to do, and what do we do when we greet people? Some people are foolishly, in my opinion, trying to promote the idea of bumping elbows. I don't think that's a good idea, because we just taught you to sneeze into your elbow, right? So if you bump elbows with somebody, you stand a better chance of transmitting the droplets that are on their elbow over to your elbow, and then the next time you sneeze into your elbow, you're going to pick them up. Right? So I don't recommend that. I wouldn't recommend elbow bumping as an alternative to handshaking. All right, so the idea of handshaking is an ancient Mediterranean custom. It was, invented in Rome and Greece. It was meant because men used to walk around carrying swords and daggers, and if you the right hand was the hand that you grasped your dagger with. So if you give somebody your right hand, it proves you're not going to stab them. You're not going to grab a dagger from underneath your toga and stab somebody if you're holding their weapon hand. Right, so that's where the tradition started. Other cultures didn't have handshakes, and maybe it's time for the Western culture and everybody else to abandon the handshake as a form of greeting. All right, so what other techniques can we use if we're going to abandon the handshake? Okay, so as I said, Bumping elbows is not a good idea, right? Saluting is fine if you're in the army, otherwise you look silly. Bowing is okay in many parts of Asia. Other cultures might have trouble adopting to that. What about if somebody tries to shake your hand and you just put your hands in your pocket so that you can't? That's a good idea. This one, the hip bump, is rather silly. I can't picture people doing that. Most people doing that. The namaste is an Indian tradition. Fine if you're an Indian. If you're from some other country, it may look a little silly. The foot bump, again, I think is silly. So that leaves us with the good old-fashioned wave, which I think everybody would be just fine doing that as a greeting instead of any of these other alternatives to the handshake. So we may have to dispense with the handshake entirely in the future. I think if everyone gets into the habit of waving, we'll probably be all right. That habit will catch on quite naturally because already people wave at each other, and it's only under certain circumstances that somewhat more formal circumstances that you shake somebody's hand. But waving, everyone does that. It's a fairly common thing. So I think my personal theory is that I think the wave can replace the handshake fairly seamlessly, very easily. All right, so instead of this, we can just get into the habit of doing that. All right, so as I said, the purpose behind social distancing, the reason why we've gone from lines that used to look like this to lines that now look like this, is due to the range for droplet transmission. Okay, and as I said, Western people in Asia, you already see this as commonplace. Whenever somebody's sick, they wear a mask. During a pandemic, everybody should be wearing a mask and everybody should be wearing gloves. But after the pandemic is over and we're just talking about spreading regular colds and flus, we should get into the habit all over the world that when you have to go to work, when you're sick, you wear a mask. Right? Doesn't matter. People think it looks silly. That's a terrible, silly excuse. In fact, it is actually a courtesy. Right? So get into the habit of, instead of laughing at somebody who's wearing a mask on the bus, thanking them. So thank you for wearing a mask and not infecting me. Right? Thank you very much. All right, so in a pandemic like the coronavirus pandemic that we're currently experiencing, it is necessary really for everyone to wear a mask, and the reason for that is because of the incubation period. People are spreading the virus when they don't realize that they're sick. Right? So for a while, until we get a vaccine for the coronavirus, we may have to actually have it so that everyone wears a mask. All right, so droplet transmission. All right, that's why they're doing it. That's why the dentist is wearing a mask and a face shield. So proper control of droplet transmission requires that you wear a mask to avoid contaminating other people, and also that you wear some kind of an eye shield or a face shield to prevent other people's coughing into your face. Right? So if this patient coughs into the dentist's face, she will get coronavirus or a cold or something like that. So that's why the dentist is wearing a face shield. Now this dentist is actually pretty good because her face shield is covering her whole face. If the face shield covers your whole face, it's actually not necessary to wear the mask, but she's just being doubly careful. Here you have this guy wearing a separate mask and eye shield. So he wouldn't be able to get away with just wearing the eye shield without the mask because this particular eye shield doesn't cover the mouth. Okay, now this is rather silly. This happened a few days ago in Michigan, where the governor of Michigan made a stay-at-home order. And in the United States, people tend to react badly to authority figures telling them what to do. So you always get a few people who insist on angrily protesting anything the government tells them to do or tells them not to do. And so here they have these protesters who showed up at the Michigan legislature, the Michigan Capitol, to protest the governor's stay-at-home order. And they have a row of policemen who are standing there preventing these protesters from getting into the legislature. And so here you see the policemen are wearing masks, which is the proper thing to do, except they're not wearing any eye protection. And here you have some imbecile who's yelling at the policemen, spitting in their face, and probably getting a lot of droplets right into their eyes. Right? So the police, in order to avoid spreading infection, you have to wear a mask. In order to prevent receiving an infection, you have to cover your eyes with a face shield and avoid touching your face. Above all, avoid touching your eyes, but also avoid touching your mouth and your nose and your ears until you've had a chance to wash your hands. So, the trick to avoid spreading or contracting diseases like COVID from droplets is you wash your hands frequently. You wear gloves. Usually, gloves help you to remember not to touch your face, but certainly when you're out around in the world, you never touch your face. You can carry a pen around in your pocket, and then you can take the ink cartridge out of the pen so that it doesn't draw on your face, and then you take the pen and you scratch your face with one end of the pen, but never the end that you hold the pen with, right? So you scratch your face with the writing end of the pen, and then you put it back in your pocket, but you only grab the pen on the other end, on the far end. Right? So you avoid scratching your face or touching your face at all costs until you get home. Then you get home, you take off the gloves, you do a thorough hand washing, and then you can usually assume that your family are the only people who are touching things at home, and if they don't have coronavirus, then you don't have to keep on washing your hands every 5 minutes when you're at home. You don't have to wash your hands every 5 minutes when you're at work or out in the world either. You just have to avoid touching your face once you've been touching things. So washing your hands is kind of a futile gesture because as soon as you touch something, they're dirty again, right? So it's better to wash your hands regularly and then avoid touching your face. And then the odds are that if you have washed your hands regularly, if you forget that you're not supposed to touch your face and you do touch your face, if you're lucky, you will have touched your face right after you washed your hands and your hands are clean. If you're unlucky, you'll touch your face after you've been touching other things, and then that's too bad. And so you might get infected that way. All right, so I'm showing you this illustration just to show you that police and people like that, they are wearing the masks to avoid contaminating us, but they have a very bad vulnerable spot in this picture, which is that they're not wearing eye protection. So when they have people yelling at them and spraying in their face, they could easily catch coronavirus from these people who are protesting. All right, now, what if you have a lethal virus like coronavirus and you don't have a vaccine? The best possible way to deal with a virus is to have a vaccine, so you're vaccinated against it so that you can't catch it, because your immune system will jump into action and kill it. Okay, so what if you don't have a vaccine? What can you do? Okay, so you can enforce stay-at-home orders. The only way that a society can deal with a lethal virus that has no vaccine is to issue stay-at-home orders, limited if necessary, where people stay at home as much as possible. They don't go out and interact with other people. Right? You can get your groceries delivered at home, so that ends up being an essential service, delivering groceries to the home. Obviously the grocery stores can't deliver groceries to everybody, so some people may have to go out and get groceries. If they do, there are various protocols that the store should take care of. The store should only allow a certain number of people in at a time, so the store is not crowded. You may have noticed that we're already doing that in Vancouver. And the aisles of the grocery store are one way, so that people are only traveling one way down each aisle. You're not allowed to have traveling in both directions down the aisle. You can limit sidewalks so that you're only allowed to walk in one direction on each side of the sidewalk. That prevents people from crossing close together. If you're only allowed to walk one direction down a grocery aisle or down the sidewalk, you can keep your distance so that people follow 6 feet or 2 meters behind each other, and you never have somebody coming in the opposite direction who has to cross you side by side. Okay. Next, the most obvious thing you can do is to force everybody by law to wear a mask and goggles and gloves when they go out, and then you enforce social distancing in addition to that. Then you have to ban large gatherings where people get together in large crowds, so you close the schools. We've done that in BC, for instance. You shut down sporting events, and so you close the stadiums, you close the churches, you close the mosques, because these are all gathering places where people gather together and they're very crowded. Now, the interesting thing is that if you close down the schools and the stadiums and the churches and the mosques, you can actually then use those areas as quarantine areas, right? So sometimes with these kind of measures, you have to randomly sample everybody for fever. We talked about that in the last lecture. You sample everybody for a fever, or you do a PCR test. What do you do with people if you find that they are infected? You have to quarantine them. Where do you quarantine them? At home? That's not a good idea if the family is not infected, because then the family will get infected. So you have to quarantine them someplace, and you can't quarantine everybody who's got the virus in the hospital, because the hospitals would overflow that way. They don't have room. So one of the things you can do is you can convert stadiums into quarantine zones, right? So you move in a bunch of cots for people to sleep on. Those cots are usually supplied by the army, because armies all over the world usually have lots of uncomfortable cots that were made for soldiers to sleep in. And so you get a bunch of cots and you put them into, cots are folding beds. You put them into the stadiums, and then you take all the people, and if the people have mild symptoms, they can stay in the stadium. If the COVID disease that they're carrying gets worse, then they can go to the hospital. But this is a kind of a nice arrangement, that if you're going to ban large gatherings, then you have the option of turning the venues for those gatherings into quarantine areas. If you have to shut down air travel, then the hotels remain empty, and then you can turn the hotels into quarantine areas, right? So you convert all of these places into quarantine centers. Right. And then you start randomly testing the population using a cheap method. Example, temperature, right? So it's very cheap to test the temperatures of a lot of people, and you can check if they have a fever. Another way is for the coronavirus, for instance. One of the symptoms of the coronavirus in the early incubation phase, one of the symptoms that you have coronavirus infection is that you lose your sense of smell. So a really cheap way to test people at random checkpoints is to just have two little bottles of scented oil. You have one bottle that's mint and one bottle that's cinnamon, and the person who's doing the testing holds the bottle behind their back, and so the person who's doing the testing knows which bottle is which, and then you hold the bottle up to somebody's nose and you say, is this mint or cinnamon? If they can't tell, they probably have coronavirus and they need to be quarantined, right? So that's a very, very cheap way to randomly screen people, and then you remove people who have the coronavirus from the population, and therefore you stop it from spreading. In some cases, you have to rely on a more expensive method to detect the coronavirus earlier, which is like PCR testing. And so you would rapidly test healthcare workers, because healthcare workers are the most likely people to spread the coronavirus or to bring it home to their family, which is a danger, right? So if you have nurses who are going and tending to people who have coronavirus all the time, they stand a better chance of getting infected, which is one of the reasons why we're grateful to the nurses and the doctors. You notice in Vancouver that every day at 7 o'clock, people come outside and they blast their horns and they bang on pots and pans to make noise. That's meant to be a gesture of appreciation to the hospital staff, who are putting their lives at risk to take care of our sick fellow citizens, right? So the healthcare workers stand a greater risk at being infected, and if they become infected, they stand a greater chance of spreading it to other people, because they're in contact with a lot of sick people. So if you have to prioritize who gets the expensive PCR testing, it's probably better to determine which people are going to get the expensive test, and you would frequently test healthcare workers. And then finally, you have to have a mandatory quarantine to remove these people from the population so they don't infect others. And then you have to ask them, who are the people that you've come into close contact with recently, and then you have to either test or quarantine all of those people as well. All right, example. Here's a good example of what happens when you do these things versus if you don't. Right. So for example, the United States and South Korea reported their first COVID-19 cases on exactly the same day, January 20th, 2020. South Korea immediately initiated random testing, forced people to wear masks, forced people to stay inside. They had roadblocks where they were testing people's temperatures by the forehead infrared camera, and the United States didn't at first. Okay, now at this point, the Korean isolation technique worked, because the rate of deaths per million, note this is per million, meaning the death rate is prorated. The Korean death rate per million from coronavirus is 5 deaths per million. The United States, who didn't do those things, the death rate is 230 per million. Right? So it's many, many times higher. Right? Now, the reason why you have to prorate the data is you say, well, there's something like about 2,000 people who've died of coronavirus in South Korea, and there are 70,000 people who've died of coronavirus in the United States. And if you point that out to people, they'll say, well, yeah, but that's because South Korea has a smaller population than the United States, so you can't compare them directly. That is true. So you prorate the data. You, instead of talking about the number of deaths, you talk about the number of deaths per million as a percentage, or as a per million number, right? So these data are directly comparable to each other because we're talking about the number of deaths per million, and it doesn't matter that Korea has a smaller population than the United States. The cities in South Korea are the same size. So one of the other criticisms of this kind of a comparison is you would say, well, but can you compare a rural country to an urban country? Can you compare a country where everyone lives far apart and there are no dense population centers? Can you compare that to a country that has a lot of big cities where people are living in close proximity to each other? And that criticism is true, but not in the comparison between South Korea and the United States, because both South Korea and the United States both have a number of approximately equal numbers of people living in the cities versus living in the country. Okay, is it possible that it's a difference in culture, right? If you make these kind of laws about you have to stay inside, you have to wear a mask, you have to close down these businesses, the South Koreans tend to do what government tells them to do because they trust their government, whereas in the United States, people actively distrust their government. It's almost an anarchist sentiment, almost a nihilist sentiment. It's almost a birthright, if you live in the United States, to criticize your government and to say they must be doing something crooked, they must be doing something wrong, and it's a conspiracy. And so that is a cultural difference. So due to the cultural differences, can you really compare South Korea to the United States for this kind of measure, the effectiveness of these kind of measures? And the answer is perhaps not. Let's look at another kind of comparison where you're comparing two countries that have very similar cultures. All right. I happen to be, like a lot of North Americans, I have a mixed ancestry, and I happen to be part Irish, part Swedish, and part Norwegian. When we talk, so my grandparents are Irish, Swedish, and Norwegian. They're all gone now. But when I was young, when we used to have family get-togethers and so on, the Norwegians and the Swedes would get together, and they would pretend to hate each other, and they would pretend that Norwegians and Swedes are totally different, and they would criticize each other and their beliefs and all that. But the truth is that Norway and Sweden used to be the same country, and they divided in the 20th century. But ever since the division, they're still essentially the same people. They speak almost the same language. They have identical views and attitudes and behaviors. They eat the same foods, and as I said, they have virtually identical attitudes towards everything. During the pandemic outbreak, Norway implemented these policies and Sweden didn't. And here we have the per million death count is several times higher in Sweden than it is in Norway. So you have two groups of people who are very Western European in their attitudes and their behaviors. There's a slightly denser population in Sweden than Norway, but it's not a huge amount. And you can see that what is the difference in infection when you simply implement a different government policy. And you can see that just by having a government policy that requires you to stay inside, wear a mask when you go out, and so on, just by having that government policy, this is as close to a controlled experiment as we can get to show that the government policy does make a huge difference. The government policy makes a very big difference. And so this I would consider as proof. Okay, how is Canada doing amongst all of these countries? Let's take a look. All right, so Italy, in terms of death per million, we're doing better than Italy, the United Kingdom, the United States, and Sweden, but we're not doing as well as Norway. The Canadian infection rate is somewhere around 122 deaths per million. The New Zealand, that's nowhere near South Korea at 5, right? So the death rate is much higher than it needs to be, but we're doing better than some countries, but not as good as others. All right, so that is droplet transmission diseases, and what do you do when you have a serious disease that's going around the world, a serious pandemic that is spread by droplet transmission, the way the COVID-19 virus is. Vehicle transmission, right? So food is a vehicle, so is water and dust and air. I mentioned that water can be a reservoir or a vehicle. Dust usually contains bird droppings. Many bird droppings contain fungal spores that spread pathogenic fungus into the lungs. So doing things, allowing dust to accumulate and then cleaning it up by stirring it up, by using measures that actually stir the dust up rather than getting rid of it, is a little bit dangerous. Okay, getting air contains a certain amount of water vapor, aerosols, and there are some diseases that spread through aerosol in water vapor. There's some diseases that spread through fungal spores that easily are transmitted through the air. Fungal spores are very small, and so they float in the air very nicely. It's a very fine mist. Eventually they will fall to the ground, but they're easily stirred up, and so fungal spores tend to be spread through air over greater distances than viruses and bacteria, for example. Transmission by vectors, some examples. Okay, so vectors transmitted usually by insects, okay, and then the vector can be mechanical or biological. So this would be an example of a mechanical vector, a black fly treading through excrement and then landing on the bun of your hamburger. Mosquito is a biological vector. It bites somebody with malaria and then bites you, and then suddenly you've got malaria. Okay, example, anywhere in the world where you have mosquitoes, humans, and monkeys, you will have malaria. Even if you cure all of the humans of malaria, you've still got the monkeys that have malaria, and the monkeys can spread it back to the humans through the mosquitoes. So Plasmodium vivax is the active agent in this case, so malaria is endemic to any parts of the world where you have humans, monkeys, and mosquitoes. Okay, the mosquito is actually the definitive host. In this case, Plasmodium vivax is a protist, so it stands to reason that a protist may have a definitive versus intermediate hosts. This is a BC Center for Disease Control map, I'm sorry, I apologize, it's right down here. There is the World Health Organization logo. I thought this map was from BC CDC. I'll show you the BC CDC map in a second. This is a World Health Organization map showing the parts of the world where malaria is endemic. Right, so this is the number of malaria cases per 100,000. Again, we have prorated the data by population. So we're not just comparing the number of malaria cases, we're comparing the number of malaria cases per 100,000 people by country. The legend is down here, so the dark red countries are more than 2,500 cases of malaria per 100,000 people. Right, so you can see the areas of the world where you have very high rates of malaria. Right, in BC, we don't actually have any malaria because we don't have monkeys. We have mosquitoes, but we don't have monkeys. Occasionally, you will see a case of malaria in BC, but it's usually present in somebody who traveled from one of these other parts of the world. This is the BC CDC map. Okay, so this is the British Columbia Center for Disease Control map showing the incidence of malaria in British Columbia, and you can see the frequency, the rates per 100,000 are fairly low. The highest rate is around 2.9 for the darkest color. So here you have 2.1 per 100,000 in this area. Right, and often that is those are a result of people who traveled from somewhere else where malaria is endemic. They didn't actually catch the malaria here. Okay, now let's look at a disease that is endemic to British Columbia. Lyme disease is caused by a bacteria called Borrelia burgdorferi. And it is spread by a tick vector. A tick is an arachnid, so you notice that the head is fused to the thorax. This is the head and thorax combined, and this is the abdomen. Right, so a tick is usually, these are human hairs that are visible here, so you can see that a tick is quite small until the abdomen becomes filled up with blood. So when you first see that, you usually don't see the tick because it's only that big, and then when it finishes sucking your blood, this abdomen fills up with blood and it's quite large, and then you know that you've been bitten by a tick because you can actually see it. They usually bite you underneath the hair, so they get underneath your hair and they bite you, and then by the time they're filled up with blood, they're big enough to actually see. Okay, so there is a reservoir for Borrelia burgdorferi. That is mice, deer mice. They live in the forest. The kinds of people who end up contracting Borrelia burgdorferi are loggers, and we have logging, of course, is a big industry in British Columbia where we cut down trees, and then so if you cut down trees, you're out in the forest where these mice live, and furthermore, you're displacing the mice from their habitat, so they are more active running around trying to find a new place to live. And so people who often catch Lyme disease are loggers or people who are out on camping trips, right? So camping people are out hiking or camping, and they stay outdoors, they sleep outdoors for a few days in a tent. They sometimes get bitten by a tick that gets into their tent, and then they have Lyme disease. There is no definitive host for this because it's a bacteria which doesn't really have any complicated life forms. Okay, by the way, we'll talk about this later, but Borrelia burgdorferi is easy to recognize. So if you don't see the tick bite you, what you have to look for is this. This is a rash that is particular to Borrelia burgdorferi. The spot where the tick bit you will be dark red, and then there'll be a light zone, and then there'll be a dark red zone around that, which we call a bullseye rash. Right? So this is an archery target. If you hit the or a dartboard looks like this as well, and the very center of the dartboard or the very center of the archery target is called the bullseye. So if you throw your dart right in the center, you say bullseye. And so they call this a bullseye rash. Right? So a bullseye rash is a telltale sign. It's a sign that you have been bitten by a tick that has Borrelia burgdorferi. You can cure it if you get antibiotic treatment. If not, you get a disease where the Borrelia burgdorferi affects your neurons, and it imitates a disease called Bell's palsy, which is a neurodegenerative disease. So for instance, you have droopy eyelids, or an eyelid that won't stay open, or a side of your face is droopy. That's usually, when that happens to you, that's either a sign that you have Bell's palsy, or that you've had a stroke, or that you're having a stroke. So if you suddenly start having one side of your face is drooping, you should immediately call an ambulance and get to the hospital, because you could be having a stroke. Right? So if you slur your speech, if you have a droopy, one side of your face is droopy, and if you can't lift both of your arms above your head, that's one of the signs that somebody's having a stroke. You suspect somebody's having a stroke, they have trouble forming words, they slur their words, half of their face is kind of droopy, and then you ask them to lift both arms above their head. If they can't do that, they're having a stroke, and you call an ambulance. On the other hand, if this occurs slowly, you develop a droopy side of your face, it's either Bell's palsy or Lyme disease. Okay, so it mimics or imitates Bell's palsy. Okay, so here's the frequency of Lyme disease in British Columbia. You can see that it's this area here, for instance, there's a lot of logging and forestry going on there as well as here. So the cases of Lyme disease tend to be concentrated in parks and also in areas where there's forestry going on. Okay, so campers, beware. Check your hair for ticks. Make sure you don't get bitten by any ticks. This is a particular problem in British Columbia in the summer. Going to provincial parks in the summertime in British Columbia is beautiful. These parks are absolutely beautiful, but you do have to, you should check your shoes every day before you put them on to make sure that there are no ticks, and check your hair regularly to look and make sure that there are no ticks. Okay, so to summarize, we talked about reservoirs, animal reservoirs versus non-living reservoirs like water and soil. We talked about how diseases are transmitted from direct contact, indirectly through fomites, directly through droplets, indirectly through vehicles, and we talked about vectors, and vectors being mechanical versus biological. Right? So a few examples of these things are also to be found in your textbook. So if you look at the tables in Appendix 3 of your textbook, you'll also find some examples. So for example, here is a list of diseases that you'll find in Appendix 3 in your textbook. Malaria is the disease, the causative agent is Plasmodium vivax, and the vector is the mosquito. That's listed. African trypanosomiasis is called sleeping sickness. It's caused by Trypanosoma brucei. It's spread by a tsetse fly vector. Yellow fever is caused by a virus called yellow fever virus, and it's spread by a slightly different mosquito. The Aedes mosquito is Aedes aegypti mosquito instead of the Anopheles mosquito. And then the bubonic plague is something that killed half of the population of Europe. It's caused by a bacterium called Yersinia pestis, and which is spread by a flea that is carried by rats. Lyme disease caused by a bacteria called Borrelia burgdorferi, which is carried by a tick vector. And here is a list of some of the other important diseases that are around the world. You can start memorizing these names, because I won't start asking you multiple choice questions about these yet, but as we start going through the course, all of the other parts of the course, I'm going to introduce you to a few new bacteria that cause diseases, and I'm going to introduce you to a few new protists that cause diseases. So eventually we will need to know all of this that's on this table. So as soon as you have the time, if you have any spare time, you can start memorizing the things that are on this table as well. And this one. Okay, one last comment about nosocomial infections, also known as death by hospital. Right. In the United States, the rate of nosocomial infections are about 100,000 people die per year in the United States because of nosocomial infection. That's a lot, and it's unnecessary because it's only a result of the hospital not being sufficiently cleaned. In Canada, we have about 12,000 people die of nosocomial infection, but notice that the population of the United States is 10 times higher than Canada, which means that we actually have a higher nosocomial infection rate than the United States. Right? So in Canada, we like to boast about our healthcare system, but we have a serious problem with nosocomial infections. So Canadian citizens should be raising a fuss about this to their politicians and demanding accountability and saying, what are you doing to lower the rate of nosocomial infections? Why do you have so few hospitals that have overcrowding in terms of beds? And why are you not giving the cleaning staff enough time to clean the hospital rooms before you put in new patients? Why are you not implementing proper handling and proper hand washing protocols in the hospital? Right? So the rate of nosocomial infection is actually 20% higher in Canada than it is in the United States, and there has been a 40% increase in the rate of nosocomial infections during the last 20 years, and not coincidentally, that is because we've been cutting back on budgets for hospitals in the last 20 years in most parts of the world. The reason for that is because we actually haven't been cutting back in the budget per se, but we've been cutting back on the budget per hospitals per unit per population. And the reason we've actually been spending more money on hospitals but less money per patient. And the reason for that is because the baby boom generation, those are the people who were born between 1945 and 1961, the baby boom generation are now at the age where they're starting to get sick more often, right? So when you're young and you're healthy, you don't go to the hospital very often. When you get older, your body is weakened and more things go wrong, right? So some people say, well, why are we spending all this money on the elderly? What about everybody else? Well, in a civilized society, you spend the money on the people who need it, right? So everybody pays taxes, and it gets spent on the people who need it. So for instance, my wife and I don't have any children, but we pay taxes that support the schools to educate other people's children, and we don't complain about that. So we don't say, well, we shouldn't have to pay property tax to support schools because we don't have any children. Right? So that's not the way it works in a civilized society. In a civilized society, everybody pays taxes, and then the people who need it most are the ones who get to use it. So the school analogy applies equally to hospitals. You say, well, I'm not sick, and I'm young, and I'm healthy, and I take good care of myself. Why do I need to spend all of my tax money on people who are either old or people who are not taking care of themselves, people who are engaging in dangerous life activities, like the people who are intravenous drug users, for example. It's their own fault they're using drugs. Why should I have to pay when they get hepatitis, right? So in a civilized society, we have to tolerate that to a certain extent, and it's not a problem that the people who have not done anything wrong just happen to need medical services more than some other people. It's not a problem that elderly people need medical attention more than young people. That's fine. That's the way life is. So just as we all pay for schools to educate children, whether we have children or not, naturally, people who are young and healthy should pay taxes for hospitals for people who are older and infirm. Now, because of the way demographics has worked, it just so happens that we have kind of a bulge of elderly people who are now entering the hospital. That's the baby boom generation. And that bulge will subside, and then we'll have another boom later on with what's known as the echo boom. But we will go through periods in history. Every country and every nation will go through periods in their history where they go through where they need the hospitals more and where they need the hospitals less, right? And so we, as a society, people who are involved in public planning, planning for the future, planning urban development, planning the structure of taxes and the structure of who pays the taxes and things like that, need to take all of this in mind. So at the moment, we're in a bit of a problem because in the last 20 years, the planners and the politicians have not taken into account the fact that there will be more elderly people in the hospital needing the hospital now and also over the next 20 years or so. Right? So this is a problem that we have to deal with. And one of the symptoms of that problem is an increase in nosocomial infections. Now, you may have heard that the coronavirus is going around killing people, and it's killing people disproportionately in hospitals and nursing homes. That means that in those nursing homes and in those hospitals, people are getting the coronavirus because it's being spread as a nosocomial infection. And it is being spread as a nosocomial infection because the hospital staff does not have enough time to clean the rooms. They're not given enough time to clean themselves properly. The hospitals and the nursing homes are overcrowded. Too many people in each room, not enough people to take care of them. If you have too many patients that are being taken care of by too few nurses, doctors, and care aides, they don't have time to take proper precautions in between touching one patient versus another. And that's how these diseases spread, through nosocomial infection. Right. So any of you students that are interested in studying political science or sociology or anthropology or public planning, if you want to get involved in the way your government and the way your society works in the future, you should be thinking strongly about the reasons for a high nosocomial infection rate in Canada. Okay, it's because we're laying off the cleaning staff. It's because we're overworking the nurses. It's because we're not treating the food preparation staff properly. They should be highly trained and they should be highly professional people. Right? So the most vulnerable people who get nosocomial infections are cancer patients, because they're in the hospital, they get radiation therapy or chemotherapy, and radiation and chemotherapy temporarily weaken your immune system. So these people are at risk of having nosocomial infections. Burn patients have a compromised skin barrier, so diseases can get in through the parenteral route, like burned skin is very vulnerable to infection. So those patients have to be taken very good care of. The elderly have a weakened immune system, so even if you go into the hospital for a routine surgery, a hip replacement for somebody who's older, and they have arthritis of the hip, they could get they're in greater danger of getting nosocomial infections in the hospital. Paraplegics and quadriplegics are people who are either paralyzed from the waist down or paralyzed from the neck down. And they sit in wheelchairs and they don't have the ability to move themselves the way we do. So if we sit, mobile people, ambulatory people, able-bodied people, sit in a chair for a long period of time, you get uncomfortable and you shift your position in the chair. Paraplegics and quadriplegics can't do that. And so paraplegics and quadriplegics often get pressure sores on their backside, right? Because they're sitting in the chair in one position too long, it develops, the tissue doesn't get enough blood flow. And then if you have a lack of blood flow to that tissue, then you get a pressure ulcer. So paraplegics and quadriplegics are in danger of getting nosocomial infections and other infections because they have pressure sores. So do diabetics. Diabetics often have pressure sores on their feet. Quadriplegics can't breathe without a machine, and neither can a lot of people who are in the hospital. And so patients who are on ventilators, that's the machine that helps you to breathe, they are also in danger of getting infected by the machine. So that's another thing that you have to make sure is very clean, are the ventilators. Okay, this is an interesting thing. So this is a television show called Marketplace, which is seen on CBC television. If you don't watch it, you should, because it's a fascinating program. And a few years ago, back in 2012, the show did an undercover expose of nosocomial. They did an investigative reporting special on nosocomial infections in Canadian hospitals. And what they did was they went undercover. They secretly went into hospitals, and in the microbiology lab, we test the efficiency of your hand washing by putting a kind of a sticky goo on your hand that is referred to as glow germ. The sticky goo is the same consistency as mucus, right? So if you wiped your nose and you got some mucus on your hand, and then you went around touching doorknobs, you would be transferring those viruses to the doorknobs, right? So glow germ is used because it's just like mucus, except that it's a fluorescent dye which you cannot see unless you illuminate it with an ultraviolet light, right? So you spread this glow germ on your hands, and then you secretly go into the hospital and you touch the doorknobs, and then you touch the elevator buttons, and you touch the sink faucets and the toilet handles, and then you touch all those things, and then you go away, and then you come back a week later with an ultraviolet light, and you illuminate all the areas that you touched to see if the fluorescent marker, the fluorescent dye, is still there. And if it is, it means it hasn't been cleaned, right? So that's a way that public health officials are supposed to be testing hospitals, right? So Marketplace, this program, did that, right? And they found that the hospitals were not being sufficiently cleaned, right? And they also discovered this statistic down here I want to draw to your attention. Canada has the highest hospital-acquired infection rate in the developed world, right? So Canada has the highest number of nosocomial infections in the developed world, right? That's a disgrace. That's an embarrassment to Canada. And so all of us good Canadian citizens and landed immigrants and permanent residents, we should all be working together to put pressure on our government to fix this problem, because it is a problem, right? So again, every country has dirty secrets, little problems that they don't like to talk about, but ignoring problems doesn't make them go away, and keeping the problems a secret doesn't make them go away. So we need to make a fuss about this, in my opinion. Okay, so this is what glow germ looks like. So they went around touching hospital handles, and they put that on their hands, and then they went around touching things in the hospital. You cannot actually see the glow germ unless you illuminate it with an ultraviolet light. Right, so here's a sink. This is not a hospital sink, but this is just a random sink that somebody has, right? And so somebody put glow germ on their hands, and then they washed their hands in this sink, right? And they wanted to get an idea of how well they were washing their hands. So then you turn on the ultraviolet light, and you can see in the bottom picture, you can see this fluorescent blue color. That's the glow germ. So obviously the person who they put glow germ on their hand, and then they washed their hands, and they wanted to see how good a job they did. You can see that obviously they made the sink completely filthy. They contaminated the sink when they were washing their hands. So this handle over here is the glowing handle right here is the hot water faucet. So they went in there and they turned on the hot water faucet when they had all of this glow germ on their hands. And then they washed their hands with soap, and then they turned the hot water faucet back off, and then they obviously recontaminated their hand after they turned the faucet back off. Right? So, all right, so that's an example of improper hand washing technique. So Marketplace went around with glow germ on their hands, and they touched various things, and they went back a month later to see if they'd been washed, and some of them had been cleaned up and some of them hadn't. So here, this is the CEO of the hospital. This is the director of the hospital explaining to the reporter that he's very sorry about this situation and it'll never happen again, and he has no idea how it happened. And so they took his word for it when they interviewed him, and then they secretly went back to the hospital 6 months later and did the same thing, and then came back with the ultraviolet light, and it was just as bad. So obviously he had not fixed the problem. But what they did find out was that the CEO of this hospital gets a bonus every time that for transferring patients quickly from the emergency ward up into the hospital wards, into the beds. So one of the problems with, we mentioned the fact that the hospitals don't have enough beds, and so sometimes people have to wait in the emergency room while a bed becomes available in the regular hospital. So this guy was getting a bonus the faster he was able to move people out of beds in the regular hospital and then move people from the emergency ward into the regular beds. So he was actually getting rewarded for not giving the cleaning staff enough time to clean the room. And so that's an unfortunate reward system that we have to rethink. We have to think twice about doing things like that. Okay, so these are, again, are the hospital-acquired infection rates. Right. This is usually caused. Some of these are nosocomial, some of them are iatrogenic. So this is UTIs are caused by sloppy insertion of urinary catheters. This is caused by improperly, not changing the dressings on surgical wounds or surgical incisions often enough. This is caused by not cleaning the ventilators properly. So these are lower respiratory tract infections, infections that are deep down in the lungs, which are very dangerous. So people who are breathing with the help of a respirator, a ventilator rather, you have to make sure that ventilator is very clean in between patients, otherwise you're just going to cause iatrogenic infections. Sloppy IV insertions for IVs. Right, so when you have an IV tube put into your blood so you can get drugs or saline into your blood, you have to make sure that site where the place where the needle is poking through your skin into your veins is kept clean. If that isn't done properly, then you get that type of an infection. Right, other things are usually include nosocomial gastroenteritis, which is caused by C. difficile. Right, so this is again a table of the most common nosocomial infections. Right. Here's a table of the most common culprits. Right. So Staph aureus is usually the culprit for surgical wound infections as well as urinary tract infections. So Staph aureus. So 30% of the iatrogenic infections are UTIs, urinary tract infections. Right. And of those 30%, 80% of the time, it's caused by Staph aureus. Right. And so you can look at these other statistics here as well at your leisure. Right. All right. Now, I know this was a very long lecture, but it's kind of redundant. It was meant to be redundant. I said the same things over and over again. I did that on purpose. So at some point you will be examined on these things, and so you should have learned these terms, these terminologies very well. Okay, so now proceed whenever you can to Unit 4, where we're going to talk about how to identify different types of bacteria based on their shape and other characteristics that they may have. So identifying things based on shape and appearance is called morphology, the study of things based on shape. And I'll see you at that lecture. Thank you very much.